All right, awesome. So now that you guys are all settled and we've gotten our little quirks out, I'm going to turn it over to my friend John at AIMx Podiatry. They are a distributor of Liposana in podiatry, and he's going to introduce our speaker. And then, like I said, type your questions into the Q&A. We'll get all of those answered at the very end. So John, take it away.
Thanks so much, Anne. So yeah, I'm John with AIMx Podiatry. Thank you all for joining. It's great to see a lot of familiar faces here. It seems like we have another great crowd, so we really appreciate everybody's interest. It's my true honor to introduce Dr. Kerry Zang tonight, even though I'm not sure that he actually needs an introduction. I've received a lot of really nice phone calls and texts this week about Dr. Zang, so great compliment to things that he's done out there in the field. So he's a prominent leader in regenerative medicine and fat pad atrophy, and he has a cash pay and advanced technology practice in Scottsdale, Arizona. So without further ado, Dr. Zang, the floor is all yours. Thank you, everybody.
Thanks, John. Well, it's nice to be here. And for all those that said nice things about me, thank you very much. So tonight we're really gonna talk about regenerative medicine, Liposana in particular, and why it matters. Well, here's why it matters. For the first time, we are able to transform our practices from being reactive to proactive. We can actually address causation and not just treat the symptoms. Now, for those of you that have been in practice for years, and for those of you that have been in practice for decades, like I've been, that's what we were weaned on. We treated the symptoms, and we did a pretty good job of it. But patients are now really, they're getting fed up with it, and they know about and hear about regenerative medicine, and they want to get better. They don't want to have to come in every couple of weeks or every month to get a shot of cortisone or to get a shot or get a callus trim. They want to get better so they can go out and enjoy their life. So regenerative medicine restores function. It helps your body or your patient's body to go ahead and to initiate a natural healing process. Regenerative medicine attracts native growth factors, stem cells, cytokines, and accelerates the healing process. And the good thing about it, it's all done in the office, it's minimally invasive, and it actually offers hope for a long-term result. So, and later on, when we discussed how I talk to patients about their problems, just try and remember what we just spoke about now. You know, in the 80s and 90s, everything was about remove and replace. Now it's all about regenerate and restore. So, how common is fat pad atrophy? Well, just think about it. We all see plantar heel pain and plantar fasciitis, and depending on who you read, it's the second most common cause of heel pain. And some sources you'll read will say it's 11% of your heel pain patients. Some will say it's 14%. But whichever ones you read, those either one are probably close to being accurate. Fat pad atrophy is only 1 percentage point behind. And that's one of the reasons why when we treat our patients with reactive medicine, which is the cortisone shot, some of them get better and some of them don't get better. And it's the #1 cause of metatarsalgia. And 80% of the population, some point in their life, will have metatarsalgia, which is actually secondary to fat pad atrophy. So all the neuromas, the capsulitis, the plantar plates, almost everything we see, fat pad atrophy plays a role. And in heel pain, 30% of Americans over 60 will have heel pain secondary to atrophy, and 50% of those over 70. So why has it been overlooked? It's been overlooked because we didn't have a treatment for it. You focused on the symptoms, but not the cause, because if you found the cause, you couldn't treat it. Well, when you think about the legacy therapies, just think about how far back we go in treating these conditions. There was a time when we were given silicone injections. Even before that, we were doing the old osteoclasis procedure. You make a small incision, you cut the metatarsal neck, you let it float, and you get rid of the callus underneath whatever metatarsal head that you sectioned, and then you develop calluses under the two adjacent ones. So we then went into the silicone, and silicone worked great until it was absorbed and carried to your lymph glands. And then we used other types of injections. Dermal fillers were present, and we used those, and they're still being used now. Sculpture works well, but it's only for a small period of time. And actually, the problem was not overlooked. We didn't have an effective treatment, so we never really bothered even giving it a diagnosis. So when we talk about the legacy therapies, steroids we'll really talk about, and seriously, I don't even know why we have to talk about steroids. We know they're not good. And the patients, our patient population now, they also know it's not good. They've been told by their physicians, other podiatrists, orthopods, well, I can give you 1 or 2 of the cortisone injections. I can't give you more than that because it's not good for you. And seriously, did we think that patients would accept that? If the second and third cortisone injection is not good for you, is the first one supposed to be good for you? You know the problems that can bring. And then we would give them the NSAIDs and the anti-inflammatories or the psychotropic drugs like gabapentin. All of those promote chronic conditions, which leads to low-grade and progressive degenerative processes. And most of the time, it leads to a surgical result. And analgesics, well, physicians really were partly at blame for the opioid crisis. Why is diagnosing atrophy, and why does it matter? It matters because it gives the patient an explanation for their chronic pain. It impacts functionality. You get quality of life issues from it. And when you have an accurate diagnosis, this guides you for targeted treatment. You get targeted treatment for a specific problem, you reduce the complication rates, and you actually get good results. So the impact of diagnosing it is you change from being reactive to proactive. Regenerative medicine treats the cause, not the system. It actually gets to the root of the problem. So, is reversing liporegression possible? And yes, it is possible, and what is the answer to that is human cryopreserved adipose tissue, which is Liposana. There's no competing product on the market for it at this point in time. So one of the major things that we have that we really need to focus on, and you'll hear about it later on in the talk too, it's really regression. You have vasoregression, neuroregression, and liporegression. And what causes that? A lot of the things that we were doing to get the quick fix, steroids, analgesics, not controlling repetitive stress. We have the opportunity now to deal with the causation. We deal with the causation, we have a true opportunity of resolving the problem. So what is the cryopreserved allograft? It's an extracellular matrix scaffold. It promotes tissue regeneration, angiogenesis. It supplies the structural support and volume restoration that's necessary to control it. The Liposana actually goes right to work. It doesn't resorb. It integrates within the host's normal tissue. It remodels within the extracellular matrix, and the cellular fragments that are there, there's no viable cells in it, but the cellular fragments actually cause your host to send in your own growth factors. So the allografts is a regenerative process. It actually allows you to flip the process of regeneration so that it outpaces the degenerative process. That's really what a regenerative process is. We turn over new cells, our skin changes every 20 to 30 days, and we have an ongoing process in our body where degeneration and regeneration work synergistically, and they're pretty much in balance. When you have a problem, it goes out of balance, and the degenerative process outpaces the regenerative process. We end up with chronic conditions. So when you think about our practices, what are our conditions? I started to make a list, and then it's probably almost everything that we see. You know, when you just think about we take out a neuroma, the patient gets a stump neuroma, and then we figure out, oh, maybe we should go back in and wrap some amniotic membrane around it or something like that. Well, this is a perfect place for the allograft, for the Liposana, and you don't need to do a procedure that is actually probably going to lead to further scarring and just changing the location of the stump neuroma. You can actually take some of the allograft and inject it around the neuroma, and it's just correcting. You're actually putting a bubble, an adipose bubble, around the area, protecting it from compression of the metatarsal heads. When we use it in Charcot-arthropathy, after the acute phase is over and you end up with a rocker bottom foot and there's a prominent bone on the plantar aspect of the foot that is painful, this is an ideal place for this. We know unless you're going to do a full midfoot repair and reconstruction that you're going to need to have something to control it, and orthotics are helpful, but they don't really control it. Well, I've had pretty good success with Liposana in that area, and don't be afraid to use some volume. You know, it comes in 1.5 volume units, but in areas like this, be generous when you use it, and you need to have a complete diagnosis to have a successful result. And when you do that, there's very few diagnoses that we have that are standalone. So you've got to deal with the problem. You just can't give the injection and walk away. If it's a repetitive stress problem due to faulty biomechanics, you can then use your allograft to provide the cushioning, and then you have to control the biomechanical imbalances that are present as well. When we're talking about small fiber neuropathy, that's a different area, and I talk about that in detail a little bit later on. So I'd like to save it for that area. But get a complete diagnosis and then formulate your treatment plan. So, and why Liposana? It retains the structural integrity and function of native adipose tissue. It closely mimics the natural fat tissue that's there, and ultimately in time, the extracellular matrix is replaced by the patient's own fatty tissue. So, Sculptra's been around for 20 years. Sculptra is a synthetic as opposed to Liposana, which is natural. You can expect long-term results from the Liposana, short-term from Sculptra. When Sculptra came about, it's very interesting. I've got patients that if they got relief for 13 months, every year, within 2 weeks, they would call for another injection. If it was 14 months, it was 14 months they had it. If it was 9 months, it was very consistent. And that was probably the best we had until until now. When we talk about Leniva first became available commercially in 2020, I believe. And it's a good product. It was the first in this group. Success rates were high, but the product only contained extracellular matrix. Liposana contains the extracellular matrix, and it also contains adipocytes. And the adipocytes accelerate the restoration process. And now, today, I actually used the first type of Liposana that was stable under refrigeration. We no longer had to have it shipped under dry ice and to use it available. So now Liposana is readily available in refrigeration. It has a shelf life of 6 months, I believe. And then there are products on the market where you can actually harvest the patient's own adipose tissue. I think that's an issue. I think because you can't take the pro-inflammatory cytokines out of it. Your actual implant graft, the autograft, is not consistent. It depends on the patient's health, and when you use the Liposana, it goes through a very rigorous process. It's validated. It removes the pro-inflammatory cytokines, and it's consistent. You know what you're going to get, and it's easy to use. You don't have to do another procedure, which is costly, and it's not really a minimally invasive procedure, even though they like to tell you it is. Anytime you do liposuction, you run the risk of throwing some clots. So what are the advantages of Liposana? It's more than just the adipose extracellular matrix. It contains the adipocytes, and the adipocytes are the fundamental building blocks that's in this structure. It provides support, cushioning, and it integrates with the host material. This provides an almost immediate, when I talk about immediate, it's 3-4 days, patients start to notice a difference, and it sends out the biologic cues for regeneration, repair, and restoration. It actually flips liporegression into lipoproliferation. So what happens to the allograft after you inject it? As I mentioned, it integrates, remodels within the host tissue. It increases the patient's own M2 macrophages, promotes new blood vessel formation, and this provides immediate structural support, and it stimulates the natural restoration of fat process into the allograft, and it's actually replaced by the patient's own fat. So the importance is that the macrophages support blood vessel formation and attracts native cells. You know, when you look at this and you read the packet insert, there are no live cells in Liposana. But what happens is the Liposana processing renders the cells non-viable in the sense that being metabolically active, they're not metabolically active. The allograft is designed to retain the native structure in the fragments and the inherent properties of the adipose tissue. And this includes the components of the extracellular matrix, the potential of the growth factors, and the signaling molecules, so that it actually starts a restorative process. They're important. They are very important because they're the building blocks of the cushioning and support system, and the scaffolding is necessary for the native structures to adhere to themselves and to do their work. And it actually calls the native stem cells to go to the area and go to work. It actually does the work for you. So how do you build success in this? Fat pad atrophy is both a symptom and a condition. You need to establish a complete diagnosis if you're going to treat the entire condition. this is not a one-size-fits-all treatment. Even though it is an anchor treatment, it often requires a multimodality approach. Staging of synergistic modalities may be necessary. And when we talk about small fiber neuropathy, we've known now for a couple decades that it really is a vascular disease, and that's the vasoregression part. In small fiber neuropathy, we now know that the microcirculation that provides the nutrients to the small nerve fibers is non-functioning or it's dysfunctional. We're pretty good about examining the macrocirculation, and gosh knows, in the past years we've been very healthy referrers to the vascular and invasive radiologists, and they've been kind enough to diagnose and do angiography and repair stenosis of the infrapopliteal vessels, and you get a good pulse in the macrocirculation, and then they still have the neuropathy. Well, we've restored the macrocirculation, probably prevented amputation, but the microcirculation doesn't have enough juice to actually feed the small nerves. So with vasoregression, we've got to deal with that. We've got to reverse that. And we can reverse that. But with vasoregression comes neuroregression, which are small nerve fibers just degenerate and they go from being like fat grapes to raisins. And when that occurs, we end up with liporegression, which is the diminution of the plantar fat pad. And these are all hallmarks of the degenerative process. So oftentimes our protocol has to be sequential. And in a situation like that, I personally often use microvascular allografts to help restore the microcirculation. A few weeks after that, probably about 3 weeks to 3 months after that, then I will follow up with the Liposana to restore the fat cushioning, because that's part of the degenerative process. When you lose that cushioning under the metatarsal heads or under the heel, under the weight-bearing areas of the foot, depending on whether it's a cavus or plantar grade, regardless of the condition, those are the areas that constant repetitive injury doesn't allow the nerves to come back. So you've got to restore that cushion, and then fat does not regenerate itself. So hence you come in with Liposana. And when we talk about later on how you talk to patients about it, because I know that's probably a concern for some of you, we can talk about that at that time. But the success in regenerative medicine is determined by addressing all the pathology and controlling the contributory issues, metabolic, nutritional, biomechanical. And one of the things is you also establish your own team. I'm sure many of you work with certain endocrinologists, certain vascular people, internal medicine, physical therapists. You have a team to help you provide total care. Team care actually equals total care, and it makes you look good. So our patient selection. Surprisingly, most patients are good candidates or can become good candidates for liporegenerative transplant injections. There are some disqualifying considerations. Don't be a hero and try to treat somebody with uncontrolled diabetes, uncontrolled atherosclerosis, or with claudication and peripheral arterial disease. You're going to be doomed to fail, and that's not the transplant's fault. That's your fault. Another area is if you believe that steroids create a problem, I will not give the transplant to anybody that's had a cortisone injection for that particular problem. If it's just one injection, find out what was given. If it's a betamethasone semi-soluble, you can probably wait about 8 weeks. But if it's triamcinolone or Kenalog or Aristocort, any really heavy steroids, I'd wait 12 weeks after that before I would proceed with the Liposana injection or any liporegenerative one. And if they've had multiple injections, I'd wait 4 months. And I have to tell you, patients appreciate being told what's best for them. And if they want to get a good result, do this. 12 weeks, 8 weeks, even 16 weeks is not a long time for a lot of these patients. These patients have been dealing with this problem for years, and they don't get the results. So just to review, vasoregression, neuroregression, liporegression, they're all associated with the degenerative process and probably occurs in that same order. Then your job as a regenerative medicine foot and ankle specialist is to create an environment that's conducive to the restoration process. And that's why waiting leads to better outcomes. And I've yet to have a patient argue with me about that. So when you give the injection and you're giving it in the patient that meets the criteria for it, first 4 weeks, patients are noticing an improvement. 8 weeks, at 8 weeks, they're feeling good. 12 weeks, they're really pleased. After that, they're sending their friends in. So, and patients appreciate being looked after. Most have had prior care. Usually it was rushed, and clearly it was not successful because they're sitting in front of you. So just explain what the degenerative and regenerative processes are, and that to restore function takes time. But with restoration of function comes an improvement of the quality of life, and it reestablishes hope for these people. So some of the patients that we've seen have a 78-year-old hiker who spends his retirement going to different countries all around the world hiking. He had an old injury, and he had severe fat pad atrophy inferior to the 4th and 5th metatarsal heads. He used to come in probably about 5-8 years ago. I mean, he did have orthotics, helped attenuate the problem, didn't solve it. Would come in to have the keratosis debrided once every 6 months. Then it was once every 4 months. Then it was once a month. And then it was at the point where he really couldn't, he really couldn't hike anymore. And his hikes, these were major hikes, these vacations. And we used the Liposana. And even though that was a small area, I used 3 cc's and took him about 8 weeks, and then he started to hike again. He's now has no pain. He's hikes, and when they go on these trips, these hiking trips, it's like to Kilimanjaro. It's like to places in Mexico, in Europe, and their hikes are 30 miles in 2 or 3 days. And actually, one of the patients that I did today, early this morning, was a patient that he sent in who flew in from Nevada. And then we had a neuropathy patient, had chemotherapy-induced neuropathy, and we used the microvascular transplant. We had regeneration of the microvascular structure. Prior to any treatment, he couldn't walk to the mailbox without having pain. After the microvascular transplant, his walking was that he would be able to walk and walk for about 20 minutes. At 20 minutes, the pain would start in the metatarsal head area. 3 weeks ago, we followed up with Liposana in the left foot, and he's scheduled for next week to have the right foot done, and he's able to walk again. And this is a hunter. He likes to hike, and they're actually wanting us to try and do the procedures more quickly in a more timely manner. But it's better for him that we do it in this manner. And then we had a 75-year-old woman, pre-ulcer, old Charcot, the plantar aspect, the cuboid was plantarly displaced, and orthotics were helpful, didn't solve the problem. She had no cushioning. We used Liposana. 7 weeks later, she's 99% better. A year post, she came back she's from Boston. She came back 1 year post implantation. The foot that we had the problem was totally pain-free. Her left foot is starting to bother her. She did not want to wait for that to get to the same point, and she requested the implant in that area. Liposana allows these patients to return to activities that they used to take for granted. These patients want to walk their dog. They want to go pick up the mail. They occasionally want to go grocery shopping. They want to walk with their family or friends. They want to play pickleball. The list goes on. So, I mean, it's very gratifying because you're actually affecting a positive result, and they're appreciative. Patients are thanking you, and they're sending in their friends. I mean, I enjoyed a fairly robust surgical practice in my first several decades of practice, but I've never had the patient response like I'm getting now. So, I mean, they're non-covered services, but when I talk to the patients, I talk to them and I tell them what their problem is, and I explain to them the effective treatments that are available. I tell them flat out, cortisone is not in my armamentarium. Cortisone is not good for them. Cortisone is cytotoxic to cartilage. It is cytotoxic to collagen and for tendons, and we all know it. I'm amazed how we are still giving it. I had a patient that came in for chronic heel pain, and their prior treatment was a cortisone injection every month for 6 months. I mean, that's really that's I don't even understand. I don't even know how to respond to that. So and I don't offer them a treatment because when they ask if it's covered by insurance, I tell them I don't work for the insurance company. I work for them. The insurance company would much rather have them get a $40 reimbursement cortisone injection. And I don't even know why that's true, because ultimately they're going to be spending tens of thousands of dollars for hospital or outpatient surgical center fees for the reparative work that needs to be done. And I'm treating them. They're not their insurance company, and they know it. Patients now know that cortisone is not good for them, and they're now running away from the physicians that still do that. And people ask me, other docs ask me, well, it's expensive and patients can't afford that. Well, as soon as the doctor tells me that, my response to them, quite frankly, is the problem's not with the patient. The problem's in your own head. If you're thinking about what it's going to cost them and you're afraid to offer it to them, then you're not really offering them what's best for them. And patients feel it. So when you explain to the patient why they should not have cortisone, when you explain to the patient what regenerative medicine does, and more of them know about it than you think, your job is just to tell them what you think is going to be best for them. You tell them that regenerative medicine takes time, and it does take time. And one of the biggest things in our area anyway are a lot of the chiropractic centers that are opening up neuropathy centers, and they're giving patients anodyne treatments, 30 anodyne treatments, or they're using other treatments, red light therapy, and whatever else they're doing. And they're charging these patients $12,000, $15,000 for that. And the patients are paying it because somehow or other, they make them believe it's good for them. What you have the opportunity to do is offer them something that's really good for them and doesn't cost that amount. But I'm sure that those centers are not thinking, well, can the patient afford it or not? So that comes through. Once you start thinking that, somehow or other, the patients don't get a sense that what you're offering them is really best for them. So just think about that. When you do that, you want to give them the best opportunity to get better. So actually, what you have with regenerative medicine, you can offer patients new hope. You can't offer them a guarantee, but you certainly can offer them hope. The regenerative options are much more palatable to the patients than palliative care. Patients are tired coming back in every 6 weeks, every 6 months, or changing from soft orthotics to hard orthotics, having physical therapy for 3 months that doesn't work. And they're actually told to live with the problem, and they're never offered a way to resolve the problem. This gives you a way of restoring cushioning on the plantar aspect of your foot. Those of you that go into the office tomorrow, just for the hell of it, just ask your patients if they like to go barefoot. Those that tell you they don't like to go barefoot probably have some form of fat pad atrophy. The patient that comes in once every 8 weeks because they have a recurrent callus, which makes it difficult for them to dance or walk with their spouse under the second metatarsal head, probably has fat pad atrophy. And yeah, you can debride it and have them use orthotics and debride it every 6-8 weeks. Or maybe they're a candidate for liporegenerative therapy. And maybe they don't have to come in every 6-8 weeks. Maybe they don't have to come in for 5 or 6 years, and then you can repeat the injection if necessary. So think about what's best for your patients and then give it to them. So you really are in a position to help your patients regain the power of helping themselves. So you can have at me with questions if you want. Thank you very much for listening.
Awesome. There were a ton of questions that came in while you were talking. A bunch of them are in the chat, and some of them are in the Q&A. So we're going to get those started. John, if you want to read off a couple of the first questions while I get things situated on this end, and then I'll take over.
Yeah, for sure. So we'll just we'll get started, Doc. So have you injected Liposana into a painful joint to cushion the joint?
Well, I've thought about it, but I have not. And at this point, I think that when you have a painful joint, where's the pain really coming from? The pain is probably coming from some degenerative arthritis within the joint, but more probably from the instability of the supporting structures, the capsule and other supporting structures of the joint. So depending on what I'm seeing, I would probably, in an intra-articular joint injection, I would probably go ahead and use the microvascular allografts. However, if it's a painful metatarsal phalangeal joint, or if it's a painful joint base of the fifth met, fourth met, and cuboid area, I would check that area aside from the stability factor. If you can feel the prominence of the bones, and they don't have to be very prominent, but if you can feel that, I would probably use the Liposana in that area to provide shock absorption. When you lose the fat and you're walking on the joint under the metatarsal heads, that's shock. If you just think about if you're walking down the street and you're on your cell phone and you forget to look at the curb and you walk off the curb and you jolt your foot, hurts your whole body. Well, when you do that, that's what's happening. So you have to really evaluate where the atrophy is, and it's in a lot of places in the foot, and there's a lot of other places where we use it where you wouldn't think about it, like if there's a deep-seated corn in the web space, right in the proximal web space of the fourth web space between the fifth and fourth toes, when the head of the proximal phalanx of the fifth is kissing the lateral base of the proximal phalanx of the fourth. That's a hard area to get. I've used a bolus of Liposana in between the fourth and fifth metatarsal heads, and what I'm doing is like I'm putting a soft basketball in that joint that it actually separates the tissue and acts as a shock absorber. So to answer your question about the joint, no, that's not a primary area where I've used it yet.
All right, thanks, Doc. So you've used this more than anybody in the country. So any thoughts on rejection rate or adverse reactions?
I have not had any adverse reactions in any of the patients that I've used liporegenerative therapy on to date. And if you include before Liposana, that also includes the first one out, and we're probably talking about maybe 200 patients. But that doesn't mean I'm not going to get a reaction, but they're immune privileged. There's no live cells. There's no viable cells. So the rate of reaction should be and has been very rare.
Perfect. So it seems like we have some interest in using PRP with Liposana. Do you see any potential contraindications there? And if folks are using PRP, how long should they wait after before using Liposana?
Well, PRP is interesting. I've tried it, I've studied it, and PRP, the success of PRP is totally dependent upon the quality and quantity of the host's growth factors. And we know evidence-based medicine tells us age 38, as we get older, the quality and quantity of our own growth factors diminishes. So when PRP is successful, the patient has good growth factors. When PRP is not successful, their growth factors are not so healthy. When you're using the Liposana, you are actually injecting the extracellular matrix, and the fragments within the Liposana become metabolically active, so that patients will go ahead and they'll generate their own growth factors to the area, and then you'll get a healing response. So a lot depends. The failures with PRP are generally host related in their therapy. And then I also use a prolotherapy, which if you're going to get a good result with PRP, you'll get a good result with Prolo. Prolo tricks the tissue into perceiving they were injured, so the body will send their own growth factors to the area, and it's a constant cueing of that. But the Liposana, but I can tell you, PRP is not going to restore fat tissue, and it's not going to restore cushioning. Neither will prolotherapy. And when you're doing that, when you're using those medications to tighten up the ligaments of the joints, you're still not restoring the shock absorbing capability. And without that shock absorbing capability, you have repetitive injury to the area, and it's going to recur.
All right, perfect. I know you talked about this, but maybe one of our docs missed, but he's essentially saying if the fat cells are not alive, then what's the difference between this and previous products on the market?
Well, the fat cells are not alive, but the fragments that are dormant and that are non-viable until they are placed into the whole system, then they become biologically active. So the fragments then start the development of the adipocytes, and the adipocytes are active. They're not active when it comes out of the bottle, if you will. They are inactive. But as soon as they hit the host tissue, they just start to bloom. And that is what's present in this product and was not present in the first product.
Yeah, the really nice thing is 90% of native adipose tissue is fat cells. So this is the complete structure. So whenever it's implanted, the body's able to recognize it and begin remodeling it really quickly.
Yeah, it starts the metabolic process, and it comes that there are no live cells. There's nothing biologically active. So it was a good question.
Thank you.
There's a few questions in here asking for more information about what is a microvascular tissue transplant.
Well, if we can we save that one just for last? I want to make sure all the Liposana questions are covered first, but we'll make sure that
there's a ton of questions in here.
Yeah, we'll make sure Dr. Zhang's able to tell folks about that product quickly. But all right, Dr. Zhang. So I'm using Liposana. I'm using 1.5 cc's under 1 med head, 3 cc's for heel pad fat atrophy. Do you have recommended amounts for certain areas?
Oh, I would not. For the only area where I might use 1.5 cc's is under an isolated fifth med head. But under the second metatarsal head, I would strongly recommend really evaluating the third and fourth metatarsals as well. They may not be clinically painful, but once you start under the second metatarsal head, you really need to put some under the third and fourth, so you provide a cushion throughout the weight-bearing area. I mean, I think that's very important. I think if you just put it under the prominent med head, and it's usually plantar flexed, you run the risk of re-injuring it, or you really have to have very good orthotic control afterwards to offload that area. So when I'm doing it, I haven't found an isolated second or third metatarsal head yet that would just take 1.5. And it's really amazing. 1.5 cc's, it fills up a tuberculin syringe, but a regular syringe, there's really not a lot there. So you want to sort of fan out the allograft, so it actually gives you some shock absorbing structure on adjacent sides of the prominent med head. So I don't think 1.5 in the middle metatarsal head is going to give you the result that you want.
Perfect. All right, thanks. So guys, a couple questions about cost. Feel free to reach out to me. My information is there. Happy to send over any pricing. Doc, are there any dorsal foot applications that you're aware of?
Well, it's interesting, but I wonder how many of you have now been reading about the Ozempic foot. We have people that are losing a ton of weight, and in Arizona, it's sandal weather 24/7, 365, and they don't like the wrinkles on their foot. You can certainly use it in that area from a cosmetic point of view. You can also use it from a therapeutic point of view over the deep perineal nerve, where the most medial slip off the extensor brevis crosses over the nerve just about the midpoint of the middle cuneiform, and you can actually cushion the nerve under there. That's where people get nerve pressure when they tie their shoelaces too tight or something like that. And it's pretty effective in that area to provide cushioning.
All right, perfect. So how about a little bit about your post-application protocol, offloading for how long?
Generally, patients can return to activities, but I think offloading is going to give a better result, and I would offload it for a week or two. The extracellular matrix really goes to work right away, and you could feel that. You can feel the cushioning there, but if you give it a week or two, it's better. And I would explain to patients that whatever activity, if it's going to be a heel, then you can actually have the patients pick up an UFA slip-on around the house or something like that, which has a very high arch and is soft. And that'll offload both the heel and the metatarsal heads temporarily. If you can have them be minimally weight-bearing or active, I wouldn't want them to do any repetitive activities for a couple of weeks. Some patients, for the first 3 to 5 days, have pain that requires some Tylenol. I don't use suture. I use steri strips, and I basically put the steri strips over the injection site, and I have the patient keep it dry for 48 hours. I have the patient take a picture of it with their cell phone and text me the picture in 2 days. And then they all generally are able to go back to showering. We just want the puncture wound to be healed over. But that pain is their friend. If they're doing any type of activity that makes them think about their foot, they should stop it. Okay? The more you offload it, the more you protect it in the first couple of weeks, the faster you're going to get a result.
Perfect. All right, Doc. So I think we do have a lot of questions about the microvascular allograft that you answered, or that you mentioned. So before time is up, you want to tell the folks a little bit about that product?
There is a microvascular allograft. It is MVasc, and it's made from arterioles, capillaries, and venules, and it comes in a wafer form. It's used off-label for mostly what I'm using it for. It is approved for diabetic wounds and superficial gangrene. And the way it works in dealing with your tendinopathies or your capsulopathies or ligament issues, it doesn't really treat that. What it does do, it treats the tissue that supports the vascularization to that, and it actually grows new capillaries. And the new capillaries then supply the newfound oxygen, native growth factors, native cytokines, and it initiates a regenerative response in that area. It works well synergistically with once you start to get the revascularization, you can then use cold laser, you can use hyperbarics, you could certainly use the biomechanical control, nutritional control as well. So, but MVASC is available, and it works great for any degenerative apathy, and we see that quite a bit. But when you go ahead and you use it for plantar fasciopathy, in all probability, you've also got liporegression, and wait about 3 weeks, and then you support it with the Liposana. You'll develop a cushioning in there that the patients will feel like they're walking on a mini trampoline.
All right, Doc. So last question I'll leave you with. Like we said, you've used a ton of this. So how long is the cushioning lasting with Liposana? And you have several years of experience now. So what are you seeing?
Liposana has only been used basically in the past year and a half, 2 years. I expect that it should have a long-lasting effect unless I don't do a good job in controlling the issues that created the repetitive trauma in the first place. And one of the things is, if you're still using a lot of cortisone, then you're going to get a lot of liporegression. So you have to use mechanical control. You have to avoid the repetitive stress that created the problem, and it should be ongoing. If you can get rid of the etiology of the trauma that caused it, it should be long-lasting. It's totally different than the Sculptra, which is a dermal filler, which is synthetic, that when you put it in, the body's going to eat it away like Pac-Man. And with what we're doing now, we're actually replacing it, and it's viable. It's live tissue. It has its own vascularity. It has its own capabilities to provide cushioning. It's like the front wheels of your car. If you don't realign the front wheels, the tires are going to wear out unevenly again. So, regenerative medicine is hard work. Hell, what we do generally is hard work. So you've got to treat all of the etiological factors.
Perfect. And I think we've covered them all, right?
Yeah, it looks like it. I am going to send all the chat questions and all the Q&A over to this team to make sure that they get all the answers to you. So if there's something that we didn't cover thoroughly, don't worry, you'll get an email with more information. Is there anything else going on? Like, where can we see AIMx Podiatry out on the road? Are you guys have any shows coming up?
So the one that we are going to probably the soonest is going to be the APMA at the end of July.
Awesome.
And
so lots of people will be there.
For all you guys that are out there, if you know of any fun shows, we love to come to events. We love to come to small local events as well. So if you guys have any suggestions for us, please do let us know.
Awesome. Well, everyone, I appreciate your time. I appreciate you joining us on this Monday night. And Dr. Zang, thank you for putting together such a wonderful presentation. We have had great registration and awesome online attendance. So thank you, everyone.
Thank you very much. Yeah. Thank you for having me.
All right. Thank you guys
everyone.
so much.
Okay.
Good night.
Good night.